Good evening and welcome to this first of the 2026 Diagnostic Ultrasound in Podiatry live webinar. My name is Michael Stephenson and it's a great pleasure to be able to welcome three fantastic co-panelists with me tonight. I am really excited to be able to welcome Zoe Wilson, Alastair Oxberry and Sean Savage even. Good evening everybody and Happy New Year.
Happy New Year.
Happy New Year. Good evening.
Yep. Happy New Year, everyone.
Well, welcome everybody. How's your New Year started? Any New Year's resolutions?
I've already started mine. I've been for a run, and it felt like the worst decision I've ever made, but we went through it, and I'm going to do one again tomorrow.
Oh, fantastic! Brilliant. Well, before we get started, I know one of our ones was to try and spread the news about diagnostic ultrasound. So fantastic to welcome everybody to tonight's session. I can't think of three better people to be sharing their journeys and expertise on this subject area. For those of you watching tonight, the outline is that we're going to go a little bit through about what the diagnostic ultrasound in podiatry is about. Then we're going to have a little chat about each of our fantastic speakers' journeys into diagnostic ultrasound, and then we want to take you through a couple of different case studies so that you can get an idea of how it can work within your practice and how it can add to your clinical decision making as well. So I think what will hopefully be a fantastic, hopefully less than 60 minutes or so, but we shall see how it goes. Anybody that does want questions, one of the fantastic things about this format is that whilst we have some brilliant speakers here, you guys on the other side are just as important. So if you do have a comment, please do pop it into the comment section. And as always, we love to hear where you're from. So if you want to pop in where you're watching us from, what the weather's like, if you're hunkered down in a storm somewhere, we wish you all the best. If you're sat up in the Highlands in the snow, I'm just jealous, as I'm sure Zoe is as well, knowing her love for the snow as well. So do pop in the comments exactly where you're watching us for. And if you do have any questions at any point, do pop them in. So before we make a start then, Zoe, I know we've had a few little bits before about this, but diagnostic ultrasound in podiatry, tell us a little bit about what's it about and what's your and the other guys' visions for where this should be going.
So first of all, I just want to say thank you, Michael, for hosting us. Very excited to have such an expert host that is Michael. I know you do lots for tomorrow's podiatry and our profession, so thank you. So diagnostic ultrasound in podiatry, obviously there's loads of us that do it, which is really exciting. I kind of thought there was potentially an area where we could bring together like-minded people and, you know, create regular webinars such as this one where we can present cases and talk about how we've integrated ultrasound into podiatry and how we use it every day. I think the purpose of this evening is to show you guys, all three of us have done our PG cert and we want to show you how we're using it in practice. I mean, you know, this may result in some, well, hopefully results in some in-person courses as well. And there's lots of amazing mentors in our profession, but also in physiotherapy, in sports medicine and so on. So, you know, I think, and orthopedics and podiatric surgery. So I think, you know, we've got a real opportunity here, not only to raise the profile of what we're doing as podiatrists, but also to link in with other professions as well. So that's a little bit about, you know, the plan. And I spoke to Sean about this probably over a year ago when we first started talking about it. And then Alastair has finished his PG cert, and we actually did a course together at Alastair's clinic later on last year. And he's just so enthusiastic, like myself, like Sean. So yeah, here we are.
So fantastic. Look, I know when we've talked about this previously, and I love your analogy, is ultrasound is a little bit like the stethoscope for musculoskeletal podiatry. And I think when we've been talking about this over the last couple of weeks, months, / years, as you mentioned there, this is about really trying to make it accessible and making this a platform where we can share each other's expertise. We can make it easy for those of you that are just thinking about embarking on a journey into ultrasound and wanting to know what it's about, all the way to those of you that are regular scanners and are absolutely sort of knee deep in it. So again, everybody's insights possible. And I have to say, I think you and Alastair did a fabulous session at the Royal College Conference where we looked at case studies and talked about it. So if you guys are watching and you're online and you've got points to put in there, please, the more you can make this interacting, absolutely brilliant. Cases and talks about it. Oh, there we go. Just having a look there for it. Some fabulous to see you all over the place. I think so far we've got Edinburgh and Northampton. Abby, welcome from York. Amanda over in Northampton. Evelyn, lovely to see a familiar name as always over in Edinburgh. Lots of familiar names here. Odissa and over in Edinburgh, Rachel, but I think Gareth, you've got it for us from Queenstown, New Zealand. That's definitely probably the furthest we're going to get. But Nikki, lovely to see you so close by, up just the road from me here. Although you're just outside Edinburgh with a tiny sprinkle of snow, and makes me jealous because we don't have it here yet. Right, let's kick on there for you for it and have a look. So I think what's really great about you as a group is we've got 3 different people at slightly different stages of your journey. Sean, you've obviously been scanning for quite some time. Zoe, you're establishing yourself there, and Alastair, just at not so much at the beginning of that journey, but at the earlier stages of that journey. But also we've been through different phases because as the landscape has developed and matured, we're now seeing different understandings of what that training entails. So Sean, as I say, the old man of the group, respectfully and with expertise there, can you tell us a little bit about your journey into ultrasound and how you found your way in and what it's taken to get to where you are now?
Okay, well listen, thanks for inviting me yourself, Michael, and happy New Year, everyone. I'm delighted to be on a cold, wet Friday evening in lovely Belfast. But my journey in ultrasound started when I first did the sports med course in QMUL with Professor Nat Padiar and Simon Leck and the wonderful Trevor Pryor. And I remember one of the very first sessions, we were invited into a diagnostic ultrasound session with Dr. Chan, and I remember standing around looking at clouds on the screen, and they were pointing out different things of anatomy, and I was like, how am I ever going to learn this stuff? But I remember after about an hour, maybe 2 hours, when certain things were showed around, I was sort of saying, my God, how have I waffled along for 25 years without doing ultrasound? And that was instantly sort of how I sort of became involved in it. So we were very lucky that we had lots of machines, we had lots of patients, and we could scan everything from knees, elbows, ankles, feet, first MPJ, joints, whatever. And I mean, I was lucky to have such fabulous mentors like Trevor, Professor Nat Padiar, and so that was really where that was. But unfortunately, the course we did, it didn't really have a formal qualification at the end. So after that, I decided I need to take this a bit further because it's something we all need to be doing, and I obviously wanted to be properly qualified and insured. So myself and 2 other pods from Northern Ireland, Gareth McMullen and Claire Dobie, Claire Rooney, we decided then we would head off to Bournemouth and do our PG cert. So that's gone up now, God tonight, when I think about it now, it's about 8 or 9 years ago. So we did our PG cert, and from then we have just sort of progressed onwards. It's a tough time. It's a lot of financial commitment, a lot of time commitment, but it sort of changes your practice. And it's now an area where, I mean, I use diagnostic ultrasound every day, and you'll see in some of the case studies, hopefully you will see the benefits of it. And it's something I'm hugely passionate about. I really think that it's an area that most pods, not just if you're in MSK or sport, but anyone involved in rheumatology, even high risk wound care, vascular. It has such an amazing, as Michael said, it's the podiatrist stethoscope, and it has such amazing powers. It helps with our clinical diagnosis. It absolutely makes you really learn your anatomy. I thought I knew my anatomy until I started to do ultrasound, and it just completely changes it. So it's completely beneficial, changed my practice, and but every day's a learning day, so I'm still learning. I still go to my mentors. I'm still following the gurus on LinkedIn and any of the sports med pages, ultrasound pages, online, and it's something we will continue to learn off. And it's great to see so many pods now really getting involved in the journey, and I think that's superb. I know physios are really pushing this. We're the foot specialists, foot and ankle specialists. I think we need to take this over, because I sort of worry that if not enough of us do this, we're going to find our physio friends are really going to take things over for us. But I know we've got such an amazing amount of enthusiastic pods out there, and with people like Alastair, the Young Brigade, and Zoe, I think we can take this to another level. So that's really my story, and I'm the old man of the party, but I suppose with only 9 years experience, I'm still a kid at this. And when I see other pods, the likes of Ed Hemitridge and who've been doing this years, and Mark Barton, these are guys that I look up to. These are guys that have been doing it so long. These guys were doing exams when I didn't even know how to spell ultrasound. So I mean, these are our gurus of the profession, and we're only following in their footsteps, and hopefully other people will follow in our footsteps and take it to another level. So thank you. That's my story.
Stepping on the shoulders of giants as always there, Sean. That's certainly a case. I like to think that you've learned to spell ultrasound, but I've seen some of your bits you sent through previously, and I know
not good.
I think there might still be some learning there. So, I mean, Sean, there you can see they're progressing in that initial stages with the PG cert down in Bournemouth and the initial case accreditation. Zoe, I know you've qualified and started using ultrasound really in the last last 4 years really, isn't it? So why don't you give us a little bit about how things have changed, and again a little bit about why you came to ultrasound and what it's changed in your practice?
Yeah, I mean, when I first started looking into ultrasound, I just knew of this guy called Sean Savage. I'm not just saying that there was this guy in Ireland, and he was pioneering ultrasound in podiatry, and there wasn't a great deal of people really doing it when I kind of looked into it. And it was hard to find information. I mean, I actually bought a machine and started using it. I was looking into the education at the same time. And obviously, when you're using it in that first instance, you're bringing your machine home, you're scanning your parents, you're scanning your partner, yourself. You're like, what's this? Where am I? What am I looking at? And it was kind of thinking, I want to do this properly, because I'm a bit of a stickler for making sure that, competency I know is important to all of us. But I do feel with practice and particularly working in private practice, all of us need to be going to the nth degree in order to achieve that level of education that we need. So everybody was talking about Bournemouth. And so I went down to Bournemouth one weekend. It was about 35 degrees. And I started my journey there. And I built up a logbook. I was really lucky that my mentor, some of you may know Graham Dawson. He's I don't know if he's joining tonight. If you are there, Graham, thanks for coming on. He is a physiotherapist who works in Cumbria, and he did his training down in London. He's now teaching down in London, and he was extremely generous, and I owe a hell of a lot to Graham for everything that he did for me, helping me get to the point I'm at now. So I did this course in Bournemouth, and then everyone was talking about a PG cert, and I was like, well, that's not what I've done. So then I was at actually a sports medicine conference in Glasgow at the Royal College of Physicians and Surgeons there. And I got speaking to Mandy Abbott, which I'm sure some of you know Mandy really well. She's an amazing podiatrist and lecturer at GCU. And I did my PG cert in medical ultrasound, so slightly different to some others, but then I subspecialized into MSK. And it's, you know, without kind of repeating what Sean has already said, it's completely transformed how I practice, how I treat patients. I think if you're a geek like myself, you love anatomy, a cadaveric course is your idea of heaven. When you can actually look inside the human body and find an issue with your patient's presenting problem, it's pretty amazing, really. So, you know, it's been, don't get me wrong, it's not been an easy journey because the PG cert was really tough. Obviously, I run a practice. I work in, you know, a few different places, and you know, that was not easy. And also the fact that there was crossover with what course was accepted as, you know, from an educational aspect. Well, what should we be doing? And so that's kind of where I'm at now. And, you know, I still invite, you know, my mentor, Graham, still comes in and spends half a day with me, and we look at more advanced techniques. We talk about cases on a weekly basis. You know, what's really nice is that everybody that's involved in ultrasound is so generous, and they all just want to, you know, support each other. So I think that's what we should be doing ultimately.
Fabulous. And I think you hit the nail on the head there, Zoe. It's about creating communities of learning where we can share our knowledge with each other and really be able to make it easy for people to first start their journey, but also, as you say, and Mark, very kind to see you there coming up through. But, you know, as you say, every day is a school day, and it doesn't matter how much experience you've had, that ability to be able to share and to learn and to have the humility to be able to keep on building on that knowledge is absolutely an integral part of both practice, but also getting the best out of these technologies. Zoe, thank you very much indeed. Alastair, you're the new boy to the group, so you know, you've started a little bit later. Tell us a little bit about your journey.
So again, as everyone else, thank you for having me on. This is really fun, and it's really quite an honor to be involved in such a group with such great people. So mine was really interesting because similar to probably a lot of people in Zoe and Sean as well, I've got my own private practice, and when I took it over, it was about 6-7 years ago now. We sort of had this sort of mission where we wanted to kind of create like a center of excellence for podiatric medicine, right? In terms of whether it was routine, whether it was MSK. And so I only do MSK, and I had a guy that was working for me who before I could do injections, he was doing injections for me, and he said to me one day, he said, "Lau, do you know I can do this with ultrasound?" And I didn't really know what he was talking about. I sort of had an understanding that you could use ultrasound for imaging and it could help, but I didn't really fully understand the power that it has. Anyway, he went on, and I got a great physio and sonographer called Stuart Wareham, who does a lot with the Brunel boys and the Smug group. And he came to work for me, and he said, Ali, I really want to do these injections guided. Could you get me one? So I found a guy called Sean Savage who had one for sale. And it was, I had really, you know, I had a lot Sean as well. He had spent a lot of time with me talking to me about what ultrasound was. And when I got this ultrasound for Stuart to do it, he sort of brought me in. And he said, Al, can I show you what I'm doing? Because I think it's going to be really important to you and what you're going to do next. So he showed me, and it just sort of blows everything out of the water when you start to realize, oh my word, this is such a powerful tool, and this takes everything out of the water, really. So when I was talking to Stuart, I was talking to Sean, I was talking to the Northern Ireland guys with Gareth and Claire, and it was all about we need to start this journey. So for me, straight away, I sort of just did a bit of research, and I thought, if we're going to do this, it's got to be right, it's got to be it's got to be to spec. So I got in touch with Brunel and the lads there, and anyone that's been on the Brunel PG cert, it is nothing short of exceptional. And I was, you know, it's quite funny. I went in there thinking, what are these physios going to tell me about the foot and ankle? And I was completely wrong. They are industry leaders in sort of ultrasound and sonography and particularly in the foot and ankle as well. So I went along, and obviously it's a huge steep learning curve. As the guys were saying before, you start to realize how wrong you are half the time, and how you're sort of second guessing yourself. You know, anatomical variation is really real, and how pathology actually looks, and you start to understand you understand your anatomy so much better, and you start to understand pathology is way more complex, and it has so much more to it, and it can really, I think for me, ultrasound has now changed the game completely. So we're no longer second guessing. You know, we can get quick, accurate diagnosis, and we can, you know, it changes our whole theory of what we're going to do in terms of our treatment plan. You know, it alters all that perspective. And I think it's not just great for the clinician, but it's great for the patient. You know, you can show the patient a real-time image of what's going on and what's wrong and how you can help. Not only that, in terms of your treatment pathway, you can show them when things are getting better, when it's less vascular, when it's less tendinopathic, when it's a really amazing tool. And I really believe that in the next 5 to 10 years, this is going to be a industry norm for MSK altogether. So I really agree with Sean when he said we need to get more people doing this, because if we're doing MSK, this is going to be a sort of standard basic minimum. And I can really see why. And it's about getting people to see that vision and understand that. And it's only going to do so much greatness for our profession. You know, it's only going to take us to another level and get us to, you know, we're always fighting our corner. And this is just going to take us into another step where we can say we are the experts in foot and ankle, and we can approach this to the highest level. So that's when I started doing it. So it's all about a clinical excellence point for me. And so now in my clinic, we've got 4 pods who can do diagnostic ultrasound. We've got a physio down. That's the whole part of the mission of what DoUp is as well. We want to start bringing this to the greater audience and getting everyone really excited about it. So that's my journey.
Thank you very much. And again, it's lovely to see that community learning you've got going on there, so that you're not only just taking it for yourself, but you're building it within your team and that knowledge as well. And again, as I say, the hope of this is that over time we build that wider community. So you've heard a little bit there about how everybody got involved, a little bit about what it brings to their clinic. Well, I think it's probably about time we actually have a look and see what that means on the ground. So fabulous group here have each put together a case study. Zoe, the ever overachiever, has managed to put 3 case studies together for us to take us a little bit of a tour of the ankle. So Zoe, should we start with yourself, and we'll work our way through one by one? How does that sound?
Sounds good. Okay. I'll keep it short and sweet. I mean, I just wanted to basically do a 360 around the ankle, because we basically had a discussion a couple of evenings ago, and it was kind of like, well, Zoe, why don't you do tib post? And I was like, well, I always do tib post. I did have a tib post image as well, and I've not included that. So there's 3 case studies that I'm going to discuss, and these are real patients of mine, all of which who have given me consent to share their cases as well. So we'll kick off with the first one. You could just go on to the next slide, please, Michael. So 55-year-old gentleman presented to me about a month ago. He spends 6 to 7 days a week on his feet. So as clinicians and podiatrists and, you know, anyone else that's joined this evening, we've got these patients that have got overload type pathology. And that may precede, a previous injury which this patient had actually had. So unfortunately, this 55-year-old gentleman was diagnosed with Parkinson's last year. So in terms of his biomechanics and his gait, he actually didn't really want to go into a lot of detail, and he's not medicated yet. But you can imagine he's kind of got that short stride length and a shuffling gait. He's not really getting a heel strike. He's also got a cavus foot type, and he's got lateral border foot pain and lateral ankle pain. He's also got a chronic kind of lateral ankle instability case here. So what I'm going to show you shortly is what we kind of saw from the ligamentous constructs that were associated with this presentation. So essentially what we've got here is a short axis view. So if we had a banana and we chopped it into slices, for those that haven't looked at ultrasound, on that image to the left, you can see a circular structure to the left. That's peroneus longus, and then brevis to the right. And in the middle, you can see a calcification, or what we would call a little bit of cortical irregularity, if you will. So that's where we essentially get a bit of bone. It's a bit irregular. So this is actually perineal tubercle. It's an enlarged perineal tubercle. So in terms of thinking about where this is in terms of the ankle, it's a little bit more proximal than the cuboid, and it's actually an area that sits on this sort of anterior aspect to the calcaneus, but on the lateral aspect. Now, what we can see on the image is that the peroneus longus is enlarged. So what we see is, I'm going to show you a normal image in a second, but essentially we've got a tendinopathic peroneus longus, we've got quite an enlarged perineal tubercle, and we've got increased power Doppler activity. So the image to the right will show you the little orange fiery bits, and that's that vascularity that Alastair mentioned. Next slide, please. So then, not the best image because we've kind of like blown it up, but if you look at the top center aspect to this screen, you'll see two little oval shapes, almost like two eyes that are kind of overlapping. And that is his contralateral side and a normal appearance of those peroneal tendons. So you can see that there's no what we call hypoechoic thickening. So that's when the tendon is larger, and we can see that there was no power Doppler activity, and the tendon itself has that echogenicity that we consider normal and continuous. Next slide, please. So then this gentleman also had what I suspect to be an os perineum. So quite interesting. You can see the tendons in long axis on this left image, and then you can see this calcification that's sitting right over the cuboid, and that's where we tend to see an os perineum, and it tends to be within peroneus longus. So really interesting case. His pain kind of went all the way down the lateral aspect of the foot, distal of the malleoli. The image to the right is an absent ATFL. So this gentleman had that cavoid foot type, lateral overload in the ankle, and on stress testing of this, which I haven't shown because it's a video and it's complex, but he had some capsular stability. So we know that the ATFL isn't the only stabilizing structure of the ankle, of course. We know that the capsule provides some of that as well. But when you stress this ankle, or you're doing a little bit of forced plantar flexion of the midfoot, you see that we get separation of that area. And next slide, please. And then I wanted to show you this image. I don't believe this is his contralateral side. It's another patient, but you can see an ATFL there. So where it's kind of going diagonally across the screen between the talus and the fibula. Next slide, please. Okay, so very quickly, we've just got one image here. Just next slide, please. So this is actually a 72-year-old female with a long-standing history of rheumatoid arthritis. So she presented to me with left-sided ankle pain, stiffness, and essentially pain that she would rate, I think, was around 8 out of 10. You can see on this left image that shows the power Doppler activity, you can see tibialis anterior over the top of the image there. So if the probe is coming from the top there, we're looking down on the tibia-talar joint, which is the tibia and the talus interacting. And we can see that kind of effusion overlying that area and the little bits of dotted orange where we've got active inflammation. And, you know, one of the benefits of ultrasound is you can look at the patient chair side and look at that active inflammation that's present. And so its application in rheumatology is fantastic. Richard Wilkins, great guy to go and speak to about this. He is hugely knowledgeable and works in a really interesting field in ultrasound podiatry and rheumatology. If we look at this image to the right, we can just see a comparable between the right side and the left side. Again, we can see this cortical irregularity around the joint margins, and we almost see that kind of step up of the bone there as the two areas meet, and that's an osteophyte. What we usually see, we can't see it massively on the left image because this is an older patient. But we usually see a black line over the talar dome of cartilage, and that's a healthy appearance in a tibia-talar joint. You can see the direct comparison with the affected side. Next slide, please. And final case study. So I had to include this because I have been speaking to a sports med consultant at length about how to manage these. So this is the very, very common, we see it a lot up here in the lakes in Cymru because everyone's up in the fells and their ankle is constantly in forced dorsiflexion, climbing the hills or running up the hills. So we can see tendinopathy of the mid portion Achilles there. So where it's what we call hypoechoic, it's got darker features and it's not as organized through the fibers. And we then see this anechoic, which means black, almost speech bubble appearance, which is anterior to the tendon. So the probe is on the top. We're looking at the Achilles in long axis. That's the calcaneus, which looks a bit like a hill. And then we've got florid power Doppler activity again, where we've got the very classic and very common retrocalcaneal bursitis associated with Achilles tendinopathy. And that's me. Oh, can't hear you, Michael, sorry.
There you go. Whoever had it on their bingo card to please unmute. Sorry about that. Zoe, a tour de force, a quick tour of everything that we could need from all angles. So thank you so much. I think it really shows the value of being able to see inside there and get a viewpoint of what's coming on and what's around the area, and just how much that added imagery helps with not just your diagnosis, but management of the patient as well. And for some of those coming through. So I suppose one thing there for those of you that are used to ultrasound, the differences are clear, but just explain a little bit about power Doppler. I know you mentioned it a couple of times there for us.
So essentially, power Doppler will show inflammation, it will show blood flow. So if you're over an area of activity, that could include a vessel, you will see the Doppler, as it were, you will see it on the screen. If you've got neovessels associated with a chronic tendinopathy, for example, or an acute or chronic effusion, you will see those spots of orange. And essentially throughout your training, you look at loads of different cases that might be mild, moderate, severe, or absent. And it's also looking at, am I over a vessel? Is the vessel compressible? There's easy ways to differentiate whether we've got, associated effusion and we've got activity because of that. But essentially, it's showing liveliness, I say to patients, or activity.
Fabulous. Thank you very much indeed. So That's as I say, a whistle-stop tour of all aspects of the ankle. Sean, I know you've brought us a really interesting case as well. So how about we bring that up for you and you can take us through your case?
Okay, well, I mean, being the usual lazy person, I decided to do not a very complex case, but probably one of the most common things that as podiatrists we'll see in our clinics on a daily basis. Well, at least I do. Plantar fasciopathy, heel pain. So really, it's not really a case study here, but I just really wanted to show you the use of ultrasound in the diagnosis of heel pain. Listen, you've got to remember too. I mean, ultrasound. If you're just using ultrasound but doing your clinical tests, you're not doing a good assessment. So you've got to do all your clinical tests. You've got to do all your history, everything, and then the ultrasound. I mean, the point of ultrasound or point of care ultrasound is really to help you along to make your clinical diagnosis. But if you're not doing your clinical tests, ultrasound is probably not the best way to do that. And when I've been with my mentors, consultant radiologists, you know, that they do all their clinical tests, they take their thorough history, and then they will use their ultrasound skills to identify pathology. So like, and the guys will tell you, anytime when we were training, you mean you've got to know what normal looks like before you can make an assumption of what abnormal is. So lots of our training, and I know even the guys at Brunel, and I was lucky even to be working there for a while. The first sort of term is really looking at normal structures. So you've got to understand how normal looks, how normal functions, and then once you're very clued into what normal is, you can very easily then identify what abnormal is. So Zoe mentioned a couple of things there. When we're scanning, we scan in two planes. We scan in what's called short axis, and we scan on what's called long axis. So long axis would be if I'm taking the heel, we're looking vertical towards the ground. The probe is if you like, 90 degrees. Or parallel with, if we're looking at the Achilles tendon or the plantar fascia, we're doing it long ways. And when we're doing it in short axis, as if we have the probe, if you like, sort of on a sideways over the anatomical structure. So each of those will show a different variation of what the anatomy will look like. And if we're going to make a diagnosis, we really need to look in short and long axis. This was very clearly identified to me. I remember by showing a slide, and it was our King Charles, I think it was getting out of a limousine, and from one side a photograph was taken, and it looked as if he was given a finger salute to the brass band. And when you looked in the other way, you actually saw that he was actually waving to them. So it really sort of gave an idea of why you should be looking in both planes. So if I look at these simple, if we look at left here, what we're seeing in the left screen, we're seeing the plantar fascia in two views here. So we're seeing it very left is it's what's called short axis, and on to the right of the left slide, we're seeing plantar fascia in the long axis. So I'll just give you a quick rundown of what we're seeing. So if you look from the top upwards, that would be the skin. Just below that, we have our fat pad, which again is very, very clearly demonstrated with ultrasound. And we get a lot of patients coming in who are diagnosed with plantar fascial issues or heel pain or plantar fasciitis, whatever. And clearly sometimes it may not be the plantar fascia. It may be what's called the heel pad, which may be injured. And the way I sort of describe heel pad to patients, a bit like bubble wrap that you wrap a present in. So when the little bubbles get burst, it's as if the shock absorption qualities of the fat pad become deteriorated, and you can get fat pad rupture, and again it can be very, very painful. And just below that we have the fascia, and the fascia, below the fascia you will see the posterior, the plantar aspect of the calcaneus. Now again, when you're looking at the plantar fascia, you know, you've got to understand the anatomy. So you've got a medial band, a central band, and a lateral band. And when we're assessing the plantar fascia, we will scan each of those bands. Interestingly, you know, lateral band plantar fasciopathy does exist. We do see that. So with patients coming in with pain around the lateral aspect of the calcaneus, which even sometimes radiates up and below the 5th MTP, don't rule out lateral band plantar fasciopathy, because the lateral band inserts just at the base of the 5th metatarsal, just around the styloid process actually. But when we're scanning then, so we will scan the medial, the central band and the lateral band. And what we want to see, if we look to the left, or sorry, to the right scan, the right one is a normal plantar fascia. So when we're assessing the plantar fascia, what we look at how it looks first. We want to see this nice sort of grey scale, what we call a nice fibrer effect. So a nice sort of linear structure, which is what we call homogeneous. So it's echogenic, so you can really see the ultrasound image very clearly. Just above that, you'll see the fat pad, and above that, we'll see the skin. So the important thing too with ultrasound is what we can do to identify whether there is an injury to the plantar fascia is we can measure that, and we can measure that in short and long axis. So when we measure an instance in this case, there is relevant data and evidence-based data that show that a normal plantar fascia should be roughly about 4 millimeters in thickness, and anything above that, usually we can assume that there's pathology. And I've seen some plantar fascias 9-10 millimeters, and I've seen some 4.3 millimeters. And again, if the whole thing is treat the patient, not the scan. And what that means is, I mean, I have a patient at the minute whose plantar fascia measures in short axis and long axis about 4.8 mils. This patient is in excruciating pain. I have a fail runner, who has a mild plantar fascial pain, and it measures something about 9.2 mils. So, I mean, just because it's thicker doesn't mean to say you're going to get more pain. So you treat the patient, not the scan. If you look then to the photograph just next to that is a pathological plantar fascia. So the first thing you'll notice, it's a lot more black, hypoechoic. The fat pad again looks a little bit more disturbed above this, and sometimes you can see some more Doppler activity in the fat pad as opposed to the actual fascia. And that's why plantar fasciopathy is not really an inflammatory condition now, as we know it, i.e. in itis, it's more of a fasciopathy. But what you can see Doppler, especially if there's a little bit of bone edema or a little bit of bony bruising, just where the fascia attaches to the calcaneus. So that's where Doppler activity can be really effective in looking at plantar fascia. But you will see it again if there's more of a fat pad irritation, fat pad rupture. And sometimes even above that, you can see like a sort of plantar calcaneal bursa, where we can see like a policeman's heel, things like that. But so these are just very simple things that you're going to see on a regular basis, and just to show you what normal versus abnormal looks like. And if you want to change the slide now, Michael, thanks. Do we have another slide? I think we do.
You do indeed. There you go.
So again, so if we go to the one to the right again, so we're seeing another variation. We're seeing a normal, which measures, if you can see there, about 3.73 millimeters, and the one to the left is 6.03. Now, you know, this is a comparison with maybe left to right, but sometimes you can see bilateral, sometimes you can see unilateral. So in this case, this was just making a comparison of left to right. The slide to the left is an interesting one. So again, this was a patient who was referred to me from another podiatrist. The patient was having he was a bus driver, and he was having extreme pain in his heel, you know, and it was the characteristic post-static dyskinesia, pain after rest, sitting driving all day. He was getting a lot of pain. When he got out of the bus, first few steps, he was in agony, and again, he got some insoles. Things really hadn't helped. He had got physiotherapy. It just really wasn't helping. So they asked me, would I have a look and scan? So first thing you're thinking, you're doing your clinical test, and he was quite tender, a little bit more distal to the attachment of the medial band of the plantar fascia. So then I scanned it in long axis, and what you'll see, if you look from the left hand side, you'll see the calcaneus, you'll see the plantar fascia, and then as it extends along the plantar aspect of the foot, you'll just see this little bulging area just slightly distal to where it attaches. So we had a wee look at this, and we looked at this in short long axis, and what we were able to see was we knew there was something going on here. This guy actually had a little tiny sort of intrasubstance tear within his plantar fascia. And this was very clearly identified on ultrasound. Now, I mean, the sort of the way I look at things, if you can get a proper diagnosis, you can formulate a proper treatment plan. So this chap had been he really hadn't been given the diagnosis of what was wrong with his heel. He'd been advised, you have plantar fasciitis, it will eventually go away. So we then found that he had a little bit of a tear. So we were able to, what I first did with this chap was just really offload. We put him in a boot, and then we got him doing a loading exercise. We got him doing a shock wave. We adjusted his orthoses. And within about 6 or 8 weeks' time, we were able to benchmark how this was progressing, which is another beauty of ultrasound. When you get a pathology and you do your treatment, you can benchmark and see how things are progressing on. And eventually, this fascia started to heal in good way. So these are just simple ways of just showing you how beneficial it can be for probably one of the most sort of common conditions we see on a daily basis, plantar fasciopathy. So that's my simple case study. Thank you, folks.
Cool. Thank you very much indeed. And again, a nice example there of exactly how you can use ultrasound in so many different ways, which is fabulous. Alastair, now I know that Zoe took us through a tour de force of the imagery, but I think you've taken us through you've got a tour de force of a case study to come up. So do you want to take us through your one?
Yeah, okay. Yeah, so I kind of misunderstood the mission when I was planning it. We're going to go with it anyway. If you guys are still with me, that'd be great. So yeah, let's go on to the first slide. So I kind of just did a case study straight away, and we can briefly just go through this. So 67-year-old male, nothing too crazy, but he did a bit of Crohn's. He had a heart valve bypass about 12 years ago, and he was cancer-free after his prostate surgery. But he was an electrical engineer. He was on his feet all day. He's a really active guy, but he was one of those guys. He only owns one pair of shoes, right? And he wears it for everything. He wears it for work. He wears it for funerals. He wears it for weddings. He has this sort of one pair of, but they were sort of narrow, tapered desert boots, and he wears them all in and out the house. So next slide, please, Michael. So yeah, this patient was actually on Monday. So when we were talking about this, we were trying to get case studies together. And I thought, this one's actually quite a useful one to do for now. So he had left foot, fifth MTPJ pain. Started about a month ago, worsened over time. I got a funny feeling it lasted a bit longer than that because he was struggling to find out sort of time frames. But there was significant swelling there, and he said he could barely walk on it, barely weight bear, 10 out of 10 pain. But particularly through propulsion, it was particularly painful. No pain in bed or at rest, but he's pretty much reduced nearly all activity because of the pain, and he's had to stop work, and it's really affecting his day-to-day life. So next slide, please, Michael. So this is, if you can see the picture here, let's go on to the next one, please, Michael, with the images. So this is actually what I was looking at. So it's sort of at a side angle, but we had this real large swelling over sort of the lateral plantar fifth MTPJ. And whenever I see these sort of swellings, when you see sort of lumps, you sort of get a little bit concerned. I don't know if you guys do, but I do. And you're thinking, whoa, what are we looking at here? And it was purple, and there were lots of, his foot was covered in chilblains anyway. But you're starting to think, you've got these sort of lighter colours coming through that fifth MTPJ, and you're thinking, is that sort of a gout? Is that a bit of tophi coming through? Not entirely sure. So the first thing I did, this patient came in for what we call just an MSK consultation, where they come in for half an hour. We do a sort of brief assessment, do a lot of history. We can do a bit of imaging to try and get some sort of diagnosis and a plan for what to do next. And straight away when I scanned it, so if you look at this image, this sort of between number 1 and number 2, you've got this sort of lighter appearance. And see, that's the fifth MT metatarsal, and that's sort of that hyperechoic structure where it's whiter. And then if you look just above it, you've got this sort of almost cystic-like structure above it, where, as Zoe was saying, you've got this anechoic image where, when it's anechoic, it usually means where sound waves can't pass through or can't come back to the probe. So this normally represents fluid. And then it's sort of got this mixed echogenicity where it sort of looks quite globular in there, and it looks, I think that this has been here for some time. Next slide, please, Michael. And then this is it in sort of short and long axis as well. We put a bit of power Doppler on it. There was some mild sort of neovascularization there, so a little bit of inflammation there. But there's definitely this sort of cystic structure. When I was looking at this, I'm thinking, are we looking at a ganglion? But I couldn't find any sort of connection with any tendon or with the joint. So I'm looking at this and I'm thinking, this looks to me like an adventitious bursa. Next slide, please, Michael. It's the video, please, mate, if that's all right. So we had a conversation with this patient about what he wanted to do. And from my experience with bursas, particularly adventitious bursas, they respond really well to just a little bit of steroid. So this is one of the other really powerful things that we can do with diagnostic ultrasound and POCUS ultrasound, is that we can use it for ultrasound guided injections. Why I think this is really important is because we know where we're putting things, right? This is gold standard, right? So I can see exactly, you can see my needle coming through. That's that sort of, it looks like a needle, and it coming into the actual bursa itself, and I'm sort of administering 1 ml of depemedrone, and you can see that fill the actual bursa itself really nicely. So we did the injection, and I just padded it up with semi-compressed felt for the day. We had a little conversation about his shoes. So he did a particular wide foot. You can tell that adventitious bursa is likely there from trauma, from pressure. He definitely had a particularly wider foot. I was unsure if there were many sort of structural changes, but it was definitely heavily loading. So I brought him in the next day because I wanted to offload it, and we essentially just did we did an X-line shell, reinforced shell with 3 mil poron, just a U-plant cover pad over the 5th MTP, just to offload it. Anyway, I had a conversation with him, and it was just the next day, and I said, "How was it?" And he said, "Pain's completely gone. I'm weight bearing, I'm walking," and it was almost miraculous, really. So we scanned it again. I thought it'd be really interesting, particularly for this case study, and it gone. The adventitious bursa had gone, and that was within a day. Now, usually with steroids, I say, look, this can take anywhere between 3 days to 3 weeks, but it just shows the power of what we're doing. We can see a condition, we can diagnose it almost immediately, and we can make a quick plan. I mean, I'm not saying steroid injections should be your first point of call, but particularly in this case, I always find that, particularly with bursas, I don't know if you guys find the same, Sean and Zoe, but bursas really tend to respond well to a bit of a steroid. And it worked beautifully. So we offloaded it, and I'm going to bring it back in 3 weeks. If it comes back, it's obviously a mechanical problem that we need to really look at, and we'll assess that. But at the minute, that was a beautiful resolution.
Alastair, thank you very much. And what I love about that is it gives the example of using it for the diagnosis, the adjunct of being able to look at your clinical decision making, but also then being used actively in the treatment of the condition as well, which is an aspect of ultrasound that we often don't talk about quite as much.
Yeah, cool.
Fabulous. Well, guys, those are some fabulous case studies there, guys. I hope that's given us a little bit of a range of some. If you do have any questions, do pop them in there. I'm very jealous because we've had New Zealand and now we have the Gold Coast of Australia. I was doing one on Tuesday and we had Barbados. If we'd had all three, that would have been the triumphant of them, I think. But quick question there from Rachel Chouette. I hope I've pronounced that wrong. Thank you for your time. Really interesting. I'm talking to Brunel about doing their PG cert. Part of the course is 100 audited scans and expected to find your own mentor. I wondered how you about how you went about this and how easy it was to find. Now, Zoe, this is perfect question to start off because this is part of what we've been talking about, isn't it? It's about trying to build a community where it makes it easier to overcome those hurdles that sometimes seem difficult. Tell us a little bit more about that.
Yeah, I mean, thank you for that, Rachel. It's a subject that we've got to talk about with ultrasound and the training pathway that we all have to go on. And an element of it for me was luck of the draw. I knew of this guy. I messaged him. I persisted. I kept messaging him until he would have me in and to shadow. And then, it's it's built an amazing relationship with him that we still have now. And, you know, we refer between each other as a podiatrist and a physio. There's mentors in all different fields as well. I know that can be difficult to access in the NHS, just purely due to wait lists and demand of those services. And, you know, these guys are essentially, you know, I mean, I'm mentoring at the moment. I'm mentoring a physiotherapist colleague of mine at the moment. And, you know, it's not easy because it's trying to find somebody to get those hours. Now, when I did my hours for my PG cert, in total was 250. You know, so some of those are all of the ones that I did of completing my logbook. He was present essentially, or if he wasn't, then he would retrospectively review my images. And, you know, so it's tough, but what we're trying to do here is create more opportunity whereby we've got these pools of individuals that are completing the PG cert. I don't know how many people now, I don't know if Sean knows, but how many people now have completed the PG cert. You know, and we've got to bring these guys into our clinics. Now, you know, ultimately, there's a huge demand on time and resources of that person who's delivering the training. So when I had my mentor, and this is part of some of the challenge, is that you're paying for your PG cert, but you're also paying for the mentorship that you're receiving. And, you know, I think that's really important as well. But, you know, what we're trying to do, Rachel, is create potentially, maybe, Alastair and I have spoke about this, mentoring days whereby students can come in, we get loads of mentors in for a weekend, let's say, and then people can come in and complete the logbooks, you know, with agreed mentors. So I think, you know, the only way we're going to get more mentors and make this more accessible for you is to do things like this and say, look, we're here, we can take somebody on, we're happy to help you. And, you know, that's kind of, you know, our plan.
And I think a part of that, sorry, Alice, I'll come to you in just one second. But I think also a part of this is a little bit of us as a podiatric community coming together and actually beginning to share our expertise together and be imaginative about how we're able to make sure that we're not just safeguarding what we're doing for ourselves, but also sharing that between the communities. And I think ideas like having that. I know that you guys were also over in Spain over the summer in doing a Gadavic ultrasound course to be able to look at that as well. And I know in the Glasgow branch is something else that I work on. We're possibly looking at trying to do that up in Glasgow in the coming future as well. Alistair, you were looking to come in there.
Only just to add what Zoe was saying, which is absolutely bang on, really. But I think when doing this, you need to be semi-proactive in what you're doing here. So when you're looking for mentors, one, we're all happy to help and we're all happy to advise. So anyone wants to message us, they can do, and we can tell people what who might be interested and where to go. But there are group chats. There is we have a DUIP Facebook group. Well, there's the podiatric ultrasound group chat. And just by putting "Can anyone mentor me" there, you know, it's surprising how many people will come forward. There also, as Zoe said, you need to approach either private practitioners, in people who are doing sonography, in podiatry, in physiotherapy, in rheumatology, contacting the Nuffield, the Spires, and just being proactive and really sort of harassing people on LinkedIn as well. There's so many sonographers on LinkedIn saying, "Can I please find someone? Do you know anyone that can mentor me?" Because by being that proactive rather than it coming to you, you'll definitely find someone.
And also being as you're saying, being proactive there, but also the more that we can begin as a community to build a virtuous circle where, you know, it's almost that case of see one, do one, teach one, not quite to that level there, but taking that through, but also then adding to that the ability to be able to sort of, you know, multiply the impact of what we have. Sean, I see you nodding along there, and
no, I just wanted to say that, first of all, mentoring is extremely important. I remember when we did it, we were at a very big disadvantage where we were pods asking docs and sonographers and radiologists, will you help us do some mentoring? And they were they were looking at us go, "Sure, you're pods. You just deal with nails and verrucas, and what do you guys want to be doing ultrasound for?" But eventually, we broke a few well, I was going to say we broke a few legs. We didn't actually. We bribed them with Irish whiskey and coffees, and I was lucky to get a fantastic radiologist, Noel Napier, and a sports med doc, Dr. Alan Rankin, who were fabulous to us and took us on board and allowed us to mentor. But why it's so important is, I mean, when I first started ultrasound, I got an ultrasound like all you guys, and you're scanning away, and you think you're scanning, well, you're not. When you see a mentor and how you're meant to scan, even the agility of using your hand and adjusting the settings and the knobology and things. I mean, I thought I knew that until first day with my mentor, and I realized, my God, I've been scanning wrong for months. So your mentor is so important, and that's why if you're going to do a course, I think some of the courses now, they really want you to have a mentor in mind first before you actually even sign up for the course. It is 250 scans, so 150 you do on your own, really, but you have your mentor to look at those, and then you have to do 100 face-to-face with your actual mentor. I'm mentoring 2 students at the moment, and they're both fabulous. They're really coming on extremely well, and it's part of the fact, as Alastair's been saying about Brunel, that they're fabulous teachers there. So these guys are really working hard. You do have to pay, and one of the reasons why you've got to pay, I mean, last year when I was mentoring, it does take a lot of your own time. I mean, when you're filling up the logbook, we've got to write 100 reports, which you can't do between patients. I mean, that takes 2 to 3 days out of your clinical time. There is a lot of time, again, even just asking patients, fitting patients, getting patients in to allow your student to mentor. So it's a big undertaking, mentorship, and obviously then you've got to examine the student as well, and there's a lot of responsibility put on you that a student is going to be given the qualification, and they're going to reach that level of competency to gain their case accreditation and their qualification. So it is quite tough, but I mean, there's lots of us out there now who are more qualified, who can mentor. In Northern Ireland, a little plug, we have set up a little ultrasound mentoring group for pods in Ireland, and we've got 1 or 2 from the UK at the moment, MSK UK Ireland. And so in that group, we have Dr. Alan Rankin, we have a Dr. Dara Rooney, who's a consultant in the emergency department. We've got 2 excellent physios, Marty Loughran and Andrew Craney, and then we've got myself, Gareth, Claire, and we've got a fabulous little group together, and we are mentoring physios, even docs. I'm lucky enough in a few weeks' time, University of Ulster have set up a PG Cert course, which initially is for physios, but I've been invited to speak to them on the foot and ankle component in the ultrasound. So really looking forward to that. But again, there's lots of physios that are going to need mentoring in their foot and ankle component. So, I don't really see an issue with the likes of Alastair and Zoe starting there. They're going to be in huge demand, and anyone who has got your qualification, I think now, Alastair, it's a year after you qualify, you can become a mentor. It's huge. There's a lot of pods going into the whole area of ultrasound. So your mentoring is extremely important, and get yourself a good mentor. Do your research, and I mean, hopefully the 3 of us can guide you, into your locality. There's people around who can definitely help you on your way. So that's just what I wanted to say. Thank you.
Sure. Thank you very much. And I think, again, it goes back to reinforce. This is a starting of a journey, and I think we'll probably end up doing a little bit of a session where we look a little bit about what mentoring involved and how we can build on that. And also, I think, as Zoe said there, part of this is these webinars, but it's also going to be about creating a group where people can share those resources and come through. And now I'm aware we're coming up to the hour mark, and so I said we would try and keep us to that point. Just a couple of Sarah Jane Walls, thank you very much. Huge commitment taking on mentee. I was lucky enough to have 2 mentors, but agree it's such a challenge. Lawrence noting there as well, the challenge with the NHS is the honorary contracts. And it is that difficulty, as we say, we often are working in isolation trying to find that out, so there's perhaps ways that we can work better to come through. Great question coming from Nikki Grant up here in I'd say sunny Scotland, but it's too dark for that. But what's a great book? Well, there you go. As Mark said, Jacobson there, it's not a cheap book, but it really does go through the detail and starts helping you guide it through. But I'd also recommend, and I'm sure you'll agree as well, Zoe, is that getting hands-on anatomy experience also really helps, because it's great being able to see it, but it's also then being able to contextualize that within its side there. So do keep an eye out for those. I'm going to apologize because we are coming to that hour mark. Well, we've overstepped that hour mark, and it's great to be able to share. We are going to do more of these. We would love your ideas of what you'd like to hear about. What aspects of ultrasound would you like to find out more about? Are the people you'd like us to speak to? We're going to try and get special guests on and get their experience and get a little bit of background understanding there as well. And we're also going to have a look a little bit about what it looks like in clinical practice as well. But we have done that hour, and I'd like to say a massive thank you to our three fabulous speakers. To thank you to Zoe, Sean, and Alastair.
Thank you.
Tour de force on all three of your presentations.
Thanks for hosting us.
Oh, absolutely. And just before we go, and I hate, well, we're all here on the Tomorrow's Podiatry, I just have to do a little plug there in that this week we released the shortlist for the Tomorrow's Podiatry Awards, and some fantastic names there forwards are coming there. In fact, I know Sarah Jane Walls is on the call, who's up for the Research Student of the Year Award, and we've got past winner Evelyn Weir, who's won Educator of the Year twice, on the call. So do check out the shortlist, and if you are around on the 2nd of March and you're coming down to the Foot and Ankle Show in Liverpool, come along and join us in person, and you can help the winners celebrate and help commiserate the runners-up. Those of you that can't make it, you can join us live online, and you can set a reminder on Facebook as well for that. Guys, thank you very much for joining us tonight. A happy new year to one and all. But more importantly, thank you to everybody that's joined us online to watch tonight and to take part. We look forward to joining you again in the not too distant future with lots more to come. But in the meantime, have a lovely evening, have a wonderful weekend, and everybody do stay safe in this cold weather. Good night.
Thanks for joining, guys. Thank you so much.
Bye-bye.
you.